one. Because we want to give your white cell count and your hemoglobin a chance to build itself back up. If you don't do that, then you actually end up killing the person. You know, it used to be, in the good old days when I first started nursing, we gave chemotherapy treatment 3 days in a row, 4 days in a row, 5 days in a row. Okay, and ultimately the patient died. We killed them. We really did. In attempting to save them, because we didn't know any better, you know, in attempting to save them and destroying the cancer cells, we also destroyed every single thing else that was good that he needed. Well, now we're much more humane. We're smarter now. And that's why our survival rate is better now. You know that our survival rate for cancer is much, much better. They're actually, I am one of them. There are people walking around who are survivors of cancer. Okay, so they give you the chemo today, all right, and usually 3 weeks down the road, they'll tell you, come back, we'll draw some blood tests before we schedule the next one. And if your H&H and your white cell count comes back at a fairly decent rate, they will schedule the next one. If not, they won't. They'll say, let's wait again. Okay? And that's a humane way of treating them. It's also a smarter way of treating them. And also remember, we've got better chemotherapy drugs now than we ever had. I mean, the chemotherapy drugs, you know, 15, 20 years ago, made your life a misery. You threw up, boy, all over the place. You were just totally miserable. Totally miserable. It was awful. If you think also that cancer drugs, chemotherapy drugs, is a poison, then if I said to you that it also affects, it's toxic to your heart, to your liver, to your kidneys, would that make sense? Certainly. Put any poison in your body and you know it's going to affect your heart, your kidneys, your liver, your lungs, your everything. When you are giving chemotherapy IV, now there's several ways you can do the chemo, and we'll discuss that in a minute. When you're giving it IV, you've got to be very, very, very careful to monitor that IV site, because you don't want any extravasation. I mean, that, if it does extravasate, which means gets out into the actual tissue itself, that is so destructive. I mean, that will eat up the skin and the muscle and the subcute. It will eat up that arm. So extravasation is very, very important to watch for. We also want to talk about some of the chemotherapeutic agents are photosensitive. In other words, you can't have them in the sunlight. Okay, I know of an oncology nurse who does home health. She actually takes the chemotherapeutic agent, she goes to the patient's house and hangs it. Okay, and that patient has a Hickman or a Portacath, and she administers it that way. She is so incredibly good with knowing exactly what drugs are photosensitive and what aren't. Now remember, she's got to have the drug in an IV bag in her car, and she's driving. Well, she knows, and she protects them not only in the brown plastic bag, she puts them in a paper bag, then in a plastic bag. She protects it very carefully, and then she goes, and then she puts it in her car. So you have to be careful, and you have to remember that some drugs are very photosensitive, and you've got to monitor the vital signs throughout the infusion. So when she goes to the house, when she's giving a chemotherapeutic agent, and she goes to the house, she gets a book. She sits down. I mean, if the patient is, sometimes the patient wants to talk, sometimes she doesn't. So she gets the book, she sits down, and she monitors the vital signs, and she does it every 15 minutes. Some people will do it every 5. Obviously, the vital signs start getting a little funny. You need to monitor it more frequently. Okay. Please remember that you never, never, never mix. You don't piggyback another medication to your chemotherapeutic drug. Please don't. I saw one person one time trying to hook up a vancomycin to a chemotherapeutic drug, and I went, this is ridiculous. You're going to kill that. I mean, it doesn't make any sense. It's useless. And also there might be an interaction between the antibiotic and the actual chemotherapeutic drug also. Okay? All right, let's talk about hormonal therapy. Tamoxifen. Well, here's the theory. Tamoxifen is an estrogen-producing or estrogen-stimulating drug. Okay? And I know that we all hear the theory now that if you have too much hormones, that can cause cancer. Okay? Understand, though, there are some cancers that respond to hormones. And that's the reason why we give tamoxifen. Okay? We give that to in some cancer situations, if the the cancer itself responds to hormones. Progestins, which is a male hormone, leuprolide, all these are hormones. Oops. These are things that we give to patients if the cancer responds to hormones. Now, if the patient is pregnant and then discovers that she has cancer, okay, she can continue to receive chemotherapy, okay, because the molecules of the chemotherapy are so large they do not cross the placental barrier, so it does not affect the baby. So she can get chemotherapy during her pregnancy. She can also get it, especially if it's breast. She can also get radiation. Of course, we shield the abdomen. Yes, we shield the baby. She can get radiation treatment as well. So if she has cancer while she's pregnant, we can treat it. It does not cross the placental barrier. If, however, she's not pregnant, okay, and she's diagnosed with some form of cancer, she gets the chemotherapy treatment, she gets the radiation, she gets fixed, she gets cured, and she says she wants to have children, what you've got to tell them is that they need to delay childbearing for at least 2 years after the chemo treatment has stopped or after the radiation treatment has stopped. Not begun, but stopped. Okay, so say it stops today. This is my last chemo treatment. I now received a clean bill of health. Well, from today forward, I count 2 years before I even think about having a child. All right, so your childbearing needs to be delayed for 2 years. Now, if the mom is pregnant, has cancer, we treat her, she gives birth. She can breastfeed if she's still undergoing chemotherapy. She can breastfeed with either breast with chemotherapy because, again, the molecules are so large they don't cross the milk barrier. They're so large. So baby is fine. She can, indeed, breastfeed. However, if it's radiation, she cannot breastfeed from the breast that's being irradiated. She can only breastfeed from the other breast. All right? That's an NCLEX question. What I just covered right there, that's an NCLEX focus, actually. Childbearing delayed 2 years after chemo or radiation. You can breastfeed with chemotherapy, both breasts. Radiation, you can only breastfeed from the breast that is not being irradiated. Okay? She can get chemotherapy treatment while she's pregnant, okay, because it does not cross the placental barrier. She can get radiation if it's breast cancer. All right, we shield the stomach. We shield the baby. Let's talk about cancer of the cervix now. We'll talk about the pre-invasive stage and then the invasive stage, and then we'll take a little break. The pre-invasive stage is when the cancer cells are only in the cervix. If they're only in the cervix, then most times these people are asymptomatic. They have no symptoms or signs of cancer at all. And how do we discover this? Pap smear. Okay, so precancerous lesions are discovered by pap smear. Okay, the treatment is cryosurgery or conization. What we do is we go in, again, this is on an outpatient basis. We go in, we freeze that area, okay, and we just remove that particular area of the cervix that has cancer. Okay. Now, I shouldn't say you're not. I have seen hysterectomies done on patients with localized cancer, localized in the cervix. But that's because it's pretty extensively localized. So they'll go and they'll remove the whole cervix. And just because it's in the reproductive system, they'll go ahead and they'll do a hysterectomy as well. Okay, so I've certainly seen that done as well. If it's an invasive cancer of the cervix, in other words, if it's in the cervix and it's in also the pelvic structures, then you're definitely going to see a complete hysterectomy. And how do we diagnose it? Well, we do a biopsy. We go do a colposcopy. We stain the cervix and we take a sample for a biopsy. Okay. If we want to know the degree or the extent of the disease outside the pelvis, then we can do a CAT scan or an MRI to figure that out. So what's the treatment if it's invasive? Well, you've got a couple of ways of treating. Okay, number one we talked about, which was the slash. We talked about cutting it out, right, conization and hysterectomies. Now let's talk about the burn portion, which is the extensive radiation. So external radiation, rather. This is when you deliver a current to the patient, okay? Internal radiation is when you put implants into the cervix, and usually if they're on internal radiation, we have them, I shouldn't say, it used to be we had them in the hospital during the entire time. Now we still do, but not all the time. Sometimes these patients can go home if they're with it enough that they can follow the directions. The other treatment, of course, is poison, which is chemotherapy, and then we talked about the hysterectomy. Doesn't matter what kind of treatment this patient's getting, whether it's chemo, whether it's radiation, whether it's surgery. Patient's going to be tired. How many of you have had surgery? Weren't you exhausted afterwards? Never mind surgery. How many of you have given birth? You're exhausted afterwards. I mean, after that, forget it. It doesn't matter what form of treatment. That person's going to be tired. They're also going to have nausea and vomiting. They're going to have headaches. They're going to be irritable. They will have skin irritation. The skin will be scaling off. There'll be erythema around, the particular area that the radiation is being administered. And the skin will also be dry, whether it's radiation or chemo, because remember, what does chemo do? Okay, if you remember what chemo does, that really does help you a tremendous amount. We talked about 3 basic forms, and now let's talk about the 2 radiation sources. Okay, you've got beam radiation or teletherapy, and you've got brachytherapy. Okay, beam radiation or teletherapy. Tele means far. Okay, so essentially what it is that the source of radiation is far from the tumor site. Let's just say that this projector here is the tumor site. Okay, this is where the tumor is. Now, the radiation source is going to be about here. So it's far from the tumor site. I'm up on the stage, and it's far from. That's teletherapy. Okay, so if you remember that tele means far, okay, you'll understand that the source is outside. It has to be far from the patient, so it's outside. In this particular form of treatment, the patient is not radioactive. Okay, so she does not glow in the dark, and her excreta are not radioactive. So she is not radioactive with this particular form. The problem with beam radiation or teletherapy is that it requires the same positioning every time. In other words, the patient has to be laying in exactly the same position. The source has to attack the particular cancer from exactly the same position. Now, in the past, what we had to do is we took this indelible marker, we marked the area, and then we brought the patient there, and they had to move the patient 50 million ways and move the radiation equipment 50 million ways. Well, today in the cancer centers, if you ever get a chance to go to a cancer center, you will be amazed. It's all computerized. Patient lays down in one particular position. Okay? They focus the radiation source on the patient, program it in the exact coordinates of the patient and the machine. Type the patient's name in so that every time the patient comes back, all they got to do is type the patient's name in, push a button, boom, there you are, exact coordinates are there. It's wonderful. It's an incredible thing. And that's another reason why our success with treatment of cancer has improved. Okay, so that's teletherapy. Requires the same position every time. The source is far from the patient. In other words, it's not right next to him. Okay, and the patient is not radioactive. Now with brachytherapy, brachy means close. Okay, so if you think about brachytherapy being close, then you understand the source of the radiation is close to the tumor. Okay, in several instances, the source actually comes into continuous contact with the tumor for a certain amount, a specific amount of time. This source is actually inside the patient, and therefore the patient is radioactive and does pose a threat to others. So his or her excreta are radioactive. You have to dispose of it in a proper fashion. the source of brachytherapy can be a solid or it can be soluble in body fluids. Now we're going to talk about a subcategory of brachytherapy being sealed and unsealed sources.